Good morning, everybody, and welcome to this first webinar of a new series where we're going to look at our community mental health transformation programme in Lincolnshire. We will get started now as we are mindful of time, and we want to make sure that we've got time to involve everybody with questions. This is going to be a series of webinars that's going to be delivered to you over the next 6 months, which will illustrate some key parts of the community mental health transformation programme, with this first one really majoring on an overview of the adult community mental health transformation principles and what we've been seeking to achieve since we've been working together since 2019. So you do have myself, Victoria Slight. I'm Head of Community Mental Health Transformation in LPFT, and my colleague Sarah.
Hi, I'm Sarah Bryan. I'm the Head of Mental Health Transformation. I sit in the ICB role, but we work as one team really, so lanyards don't matter so much for this.
Thank you, Sarah. So we are going to present to you together, but we are joined by an expert panel as well, who will be picking up some questions with you afterwards. And I'll invite the panel, if you wouldn't mind, to just flick your cameras on now so that people can see who you are. They are in the room. I can see we have with us John Mansfield, who's one of our experts by experience, Jade Corson, who's with us from the local authority, and some others with us in the room. So they will be taking some questions with us at the end of this webinar. But let's move on. So as I can see in the chat, Janine has already put in the chat, if we could just ask you to keep your cameras off and put any questions that you might have in the question and answer chat, that would be great. If you can just remain muted so that we can move through the presentation as seamlessly as possible. This session is being recorded so that colleagues who can't join us from across the system have an opportunity to come back and look at it at a later date, and we will be sharing the slides along with some associated documents after this presentation. So we'll move on. So what we're going to talk to you about, and it will be a tag team effort between myself and Sarah today as we go through, is we want to cover some key points, one being our NHS England roadmap that we've been working on, which helps to navigate where we need to go through and the key principles that we need to pick up, what we've achieved to date, some of the benefits of the transformation and how we're embedding documents such as No Wrong Door, and that's informing us around our How Are You Lincolnshire website, our population health approach, what we're going to do next and how we're going to measure that, and then we'll have some time for questions and answers. So I am going to hand over to Sarah now so that she can take us through the next few slides.
So this slide covers, as we said at the beginning, the NHSE roadmap for the adult community mental health transformation programme. This came about in about 2022, I think it was, so probably last year was when it actually came out. In fact, the programme had been running since 2019. We were an early implementer site, so one of 12 across the country that were chosen to start rolling out this programme across the county. And so what we were guided by at that original time was the long-term plan and some of the attendant documents that followed that. So there was a mental health implementation plan and a community transformation framework. And all of that had to be interpreted. And as is always the case with any sort of pilot or anyone that leads the way, we sort of started to work out what we needed to do in order to embed some of these key principles that are now really much more closely set out by NHS England. So we're now able to much more clearly map where our progress has been and what we've achieved, and equally where we still need to move forward. So some of those core elements that are outlined on this slide is that, for example, we needed to make sure we had a trauma-informed approach, and some of those concepts we'll be explaining in a bit more detail later on. And also, obviously, a personalised care approach. So making sure that we embed that within it was absolutely key. We needed to make sure we have improved access to psychological therapies. Some of them are listed there for you so that we make sure we work in a much more person-centred way. And obviously also that we have a no wrong door approach. So the idea ultimately is that we get to a stage where people aren't turned away, that you have that continuum of care and there's no cliff edges, there's that seamless provision for people. And then equally, the commissioning of partnership working with VCSE is really key, working with primary care as well, to make sure that we have lots of new roles embedded, funding invested into local communities, make sure that it's innovative, that it's sustainable, etc., across all of the PCN areas. And we did that in a phased approach through a rollout of 3 different phases over the last 3 years. We're now in that 3rd and final year, but it's not final from the point of view of where we're going to move to next, obviously. So this slide, it looks a bit of a busy slide, and I know you probably can't read all the detail on it, but anybody that wants to know more detail, we're happy to explain it, and we could talk for hours about this, really. So this is the summary of some of the elements that we needed to achieve. It just puts it into the context of a framework for you. What we needed to do was make sure that we had the model developed. So that was one key element that NHS England asked us to talk about, that the care provision is in there as well, that we've got workforce clearly set out. That's obviously a key resource element that's needing to be put in place, and that we have data. We always like to track what we're doing in terms of those outcomes. Then we've also got the dedicated focused services. So we've got some elements in here, which are the personality disorder, the community rehab, and the eating disorders are clearly elements of that. So all of these were things that needed to be worked through, and they've all got, so the left-hand column of this model is just showing you the things that needed to be put in place. And the right-hand column was the progress that we were making against all of them. In fact, since this document in May 23, we've had another one which is much more detailed, gives us some clear measures of success, and we're able to now track that progress much more straightforwardly. If you move on to the next slide, Victoria. So what have we achieved to date? So we're going to show you a couple of really busy slides that shows and puts it into context about what all of these words that we've just been talking about have really meant for us. That's just a list of some of the documents that set out the framework. If people want more detail, we're happy to share some of these documents, or you can find them online. They will set out exactly what the intention was behind this whole programme. If you move on to the next slide. So this is the first one. So as at November 23, and I'm not going to read all of these out to you, but I think there's some really key things that you need to just bear in mind that this programme has been instrumental in making sure is now in place. Obviously, we've got multi-organisational programme steering groups in place, which is really important that it involves people with lived experience. We've got lots of subgroups. There's a regular reporting structure, so that's got a whole sort of structure behind all of that. We've got 12 local project teams now that are also in place, with 9 partnership groups, and that covers all 14 now of our PCN areas. It all focuses really on the mental health and wellbeing transformation improvements, and they've all got their own mental health population profiles, which are all really important for helping to understand the needs of their local communities and can then inform some of the decisions that are then being made in those. We've got 15 wellbeing hubs, got 19 satellites. I'm going to show you some maps soon, which set out where all of those are and what that now looks like. We didn't have any of those things before. It's important to remember that. And we've got 15 whole-time equivalent community connectors in place. And now also just recently, Gail's come into post as our community connector partnerships lead, which brings all of that work together. We've got our really important social prescribing link worker service, which we've got 23 mental health social prescribers, and they work alongside the generic primary care network based social prescribers. We've got peer support workers, a lot of them employed by Shine Lincolnshire, and a few in the Recovery College. We've got quite a few nightlight cafes. I'm going to show you a map of where those are and how those have developed over the last few years as well as things like the co-production network. Huge amounts of investment. We're going to talk to you a bit about the investment that's been put in through the VCSE. And it's not just through the grant allocations that we offer out every year, but also through the investment in some of those wellbeing hubs, nightlight cafes, etc., which are also invested in through the VCSE, as well as our suicide prevention strategy support. So we've got some funding of grants through those as well. We've got 22 mental health practitioners in primary care networks. I think pretty much all of our PCNs now have at least one practitioner. Some of them have 2, and some are working on their 3rd that are working in there. Not to say that we don't work, of course, with our children and young people's programme. So, of course, we're making sure that we've got linkages in with there. So there are some children and young people, for example, mental health practitioners just starting to stand up so that we can make sure that that area of it is also covered. We've got university night worker posts. Important not to remember those particular organisations who have specific needs. So Lincoln University and BGU up the hill in Lincoln, of course, have both got those as part of our crisis alternatives offer. There's some investment gone into the the Health for the Homeless team. The HHH team has also had some support. Hey Lincolnshire, we talk about that all the time. I think that was on the background of Victoria's slide. So we'll talk to you a little bit about what that looks like, and our training offer as well. We've also got some Together We Will statements that were co-produced with colleagues, and including people with lived experience and staff some months ago now. Benefits of the mental health transformation won't be surprising, really. Things like collaborative care. This is a huge way of working very differently in an integrated way. The actual MHDLDA Alliance, as we call it, so Mental Health, Dementia, Learning Disability and Autism Alliance, has quite a few colleagues across different organisations. It is a new way of working in such a close way, making decisions together, which is really important. It involves the VCSE, it involves police, it involves district councils, not just the usual suspects of all the statutory organisations, and primary care, of course, are in there as well as people with lived experience. We've got timely and early interventions, etc. Sorry, the slides moved on, so I'll move on to the next one. So No Wrong Door is also really important. A vision for mental health. This was a document that came out and has some really core principles that we're also now embedding, which will be part of our next steps for our programme. If you just move on to the next slide, then I can just show all 10 of those principles. So there were 10 clear principles that came about through this document, and we're now starting to embed that. Whole person care is really important, that we make sure that we make sure that mental health and physical health is working together. Co-production is obviously part of that. Workforce is really key. We need to also make sure that we've got outcomes that matter as well. But prevention and early intervention, of course, is one of those key factors that need to be brought in at the beginning. So we had an event back in April where we started to work out, so what would that look like for Lincolnshire? And as a result of that work, we're now starting work programmes that help us to try and make that come to fruition. Maybe 10 years, hopefully sooner than that. So we'll see how that progresses. Victoria.
Thank you, Sarah. So how are we achieving all of this? We've just heard about all the ambitions and some of the things that we are doing, but there are some key points that we'd like to highlight. One of them is the relational frame that we work within. So how we embed relationships and continually improve those relationships, because we've got to trust each other to be able to do this. This is a person-centered, holistic approach to care that encompasses all of our partners across the whole of Lincolnshire, including our experts by experience who have an equal seat at this table. The investment into the voluntary and community sector, as Sarah's alluded to, it's not just through grant allocation, but it's also through sustainability, innovation, development. It's making sure that we're listening and we're working together in that reciprocal way. How are you, Lincolnshire? As you can see on my background, this is a web-based service directory that we've created together. It's continually growing and iterating. It's staffed by our community connectors and updated, so it's a dynamic website, and it works in partnership with other websites that you'll see in the system, such as Connector Support in the local authority, which provide the wider background to that work. But How Are You, Lincolnshire is about supporting people to support themselves with mental health and well-being. We're really keen that we use evidence, so evidence-based practice, such as our patient-related outcome measures, as much as our mental health population profiles that we started to create with our colleagues in public health. That will help us to target where we need to target more efficiently. So a really good analogy that a colleague of ours used on the call the other day, John, who's on the call on our panel, talked about how we make sure that we've got a spread of plates across the table rather than a stack of plates in the corner. So how do we do that to make sure we're addressing health inequalities? Where are those hidden cohorts of people, and how do we make sure that we're giving them the support they need? We need to make sure that we're training people, so we've got to upskill. We've got a very diverse workforce here in Lincolnshire. We're always seeking to grow and change that workforce, and we need to upskill that workforce so that they can be really confident in the delivery of the psychological interventions. If we can do that, then we've got an ability to support each other in the work that we do, and that really is informed by that trauma-informed practice, which we're going to come on and talk to. And for me, that trauma-informed practice can only be led if we have a really dynamic co-production network which continues to involve people with lived experience. So the mantra here is, we will do everything with me, not to me. So partnerships and integration sit very much at the heart of the programme of delivery, and that means that we're working right across the system. So I've talked about the co-production network, I've talked about the voluntary community and faith sector. Shine Lincolnshire are a significant partner. Kerry Stocks, who's on our panel, is here with us today from Shine Lincolnshire. Shine provides that umbrella organisation that helps to not only allocate our money into the VCFSE sector, but it also helps us to understand more about the rich tapestry. We are really, really diverse in Lincolnshire, and we have a lot of VCFSE partners working alongside us. Primary care, of course, are a huge part of what we do. So our work with our practices, our GP practices in particular, and at that population level where we started to put specific primary care practitioners in place, are absolutely integral to what we do. And then we've got other system partners such as our colleagues in ULHT, LCHS, the County Council, and making sure that we're also working right across those county boundaries. So it even says country boundaries on this side, but I think it could be both. So we work regionally and nationally, but what we were alluding to on here was where we connect in with those partners in, for example, in NWAFT or in Nottinghamshire or North Lincolnshire. So I'm going to just talk to you briefly about the work that we've done in the Mental Health and Wellbeing Community Investment Scheme. So this was a piece of work that we did about 18 months ago, where we offered about £1.5 million into the voluntary and community sector. It's a fund that we are trying to run in two ways. So one is about developing an innovation and supporting smaller organisations to have a go, to pilot initiatives where perhaps they don't feel that they've had the chance to test out if that is what their local communities really want, or they might have a really innovative idea and it's the first time they've ever done anything like this. So we offer a funding stream for that. And the other funding stream that we offer is one that's more sustainable. So we listened to the feedback from our colleagues in the voluntary sector who said, you know, it's really hard if we only have seed funding for 1 year. What we need to do is have sustainable funding. So we've worked with them, and what we do is we offer a sliding scale grant. So it starts at 100% and then it slowly drops down, so that we're promoting that self-efficacy. We're giving people the chance to apply for other grants across the system, but we're also acknowledging the need that actually for some organisations they need 3 years to be able to really cement themselves into those communities. And what we don't want to do is parachute projects in and then remove them, because as we all know, that isn't the best use of resources, and particularly when we're working in a mental health frame, we need to make sure that we're creating a safe and contained space where we can secure those relationships and those attachments that are so important to us. In addition, this fund allows us to capture some of that evidence. So the data flow is important to us. So we have a database called the Mental Health Data Set. But what that really provides to us is that ability to make sure that we are spreading those plates across the table and we're not stacking them all in the same place. So an overview of where some of those projects are happening. Now you can see that they're all across the county, which is brilliant. We've got 146 community projects across the county at this moment in time. So we're already supporting 16,500 people. And some of the things that are important are the impact. So, for example, £10,000 of investment has been reported to give us 437 hours of support for 49 individuals. We've got staff undertaking training modules that they've probably never had access to before. It's delivering that flexible person-centred approach and an increased awareness of an organisation. So I think that's important. The impact is at a person level, but it's also at an organisational level. So we're increasing local volunteer and employment opportunities. So our individual placement support service is part of this programme, where we can help people back into employment, but we're also supporting organisations to accept people back into employment who maybe historically didn't have that opportunity. We're increasing that local capacity in Lincolnshire, and we're always trying to seek to get that real strength strengths-based approach to all the community assets that we have. I'll hand back to Sarah, who'll take you through the next few slides.
Yes, so some of the other things that we've done, of course, is start to invest in some of the non-clinical roles. So, for example, some that you'll see on here is the community connectors. I referred to those earlier, and their particular roles are around identifying what those needs are in the local communities, identifying what's already out there, working and bringing organisations together, bringing people together, and trying to make sure that those partnerships are working really well together. Social prescribing link workers, people can be referred into those or signposted into those services so that they can then start to receive some support from individuals so that they can help identify what really matters to them. It's part of that overall picture that we've got for personalised care. So nightlight cafes, we've referred to those earlier. So these are largely volunteer-led. The Axe Trust were the ones who started these in Lincoln. I think we had about 8 sites that were in Lincoln, and we've now expanded that. You can see a huge list there across the whole county. It's been a really important development, all of them embedded into community settings, some of them in wellbeing hubs, some of them in other sites. All of them now provide that support in the sort of twilight hours, if you like. So after the statutory services have closed, there are a group of volunteers who will provide a listening ear, effectively, who can provide some level of support for individuals where they can actually go in and have a cup of coffee or tea and just sit down and have a chat where they may not otherwise be able to do that if other services that they may otherwise require may be closed at that time of the day or night. We've got a website on Hay, of course, which will set out exactly where these are all open and what times they're open, but it's important to know they're there so that you can signpost people to them. Newest one is in Bishop Gloucester University, so that just opened in September, fairly recently. We've also got one for young people that's just started up, so a pilot in Bridge Central in Lincoln. So we're just going to see how that works. So the wellbeing hubs, you'll have seen that huge list of initiatives that Shine Lincolnshire have helped us to put in place. So you need to know what's out there, don't you? So these wellbeing hubs, of course, are the ones who are starting to provide them in some of these settings, and some of them are obviously in lots of other places as well. They have lots of projects and initiatives running from them. So you've got, for example, Boston has got some provision in Centenary. First Coastal have got some right out there on the coast. We need to make sure that there are hubs which have the core provision of offer, and also we've got the satellites for those smaller provision that's out there, and then of course the roving outreach as well. So that it's just a label that we gave it, really, but it was a fund that we've given to some of those areas because we're aware, thinking of the rural community that we've got in Lincolnshire, need to be able to take out some of these projects and initiatives to other places. So that's in the south, similar sort of pattern, and the west, just making sure that we've got cover across everywhere. So how are you, Lincolnshire? So this, you'll have heard us mention this quite a few times. We're obviously very proud of this, and we started to work with Cambridge and Peterborough to try and get this together. It's developed with people with lived experience, and it works hand in hand with other directories that are out there, Connect to Support, for example, and some that are also held by some of the VCSE organisations. So we make sure that this is kept as up to date as possible. It has the list of all of those Shine Lincolnshire initiatives that we talked about earlier, but it also has other things that we are aware of that may well be useful for people around mental health and wellbeing support. When you go onto it, there are landing pages for the different districts, so people can look it up based on where they want to access, and that might be in your home, or it might be that you want to go further away from home. And when you go onto it, you'll then be able to see it categorised in nicely coloured little pins with little drop-down lists for different types of support and advice, etc., that are available, or different activities and initiatives. And then you can start to see, by clicking onto it, it'll come up on an interactive map exactly where it is, so that helps you then locate it. So you might want to do it by actual type of things that you're actually interested in, or you might actually want to do it by where, you know, I want to go to a particular place and what's available there. So you can look at it from a number of different routes, really. I don't know whether you want to show the next slide, Victoria, which actually shows that landing page. That's just an example of what that looks like. And when you go onto it, if you go onto the www.heylincolnshire web link that we've put at the top there, then that will also help to identify that. The other benefit of this is we're going to add some other exciting options as well, like the training offer, etc., will all be on there ultimately as well. This is a local guide that's started to be pulled together. I think this one's been done for one particular area, and it's just some quick and easy guides so people can say, well, where would I go, for example, for Mental Health Matters, which is our helpline. You've got a quick view of the number there. Hey Lincolnshire, you've got a QR code to be able to access that. Nightlight cafes, where are they? I can quickly go onto this as well. So it's just a local guide, and each of the PCN areas are developing these for their different populations. So some of them will have the same links and some will have more localized links onto them. Victoria.
So I mentioned earlier that we're starting to use some of the evidence base, and one of the things that we've been working on across the system is our mental health population profiles. This is an example of the first one that we've done. We're now developing them again, and they're going to be made available through the Lincolnshire Intelligence Hub, so that, as a colleague said the other day, we need to get that information out to people so that they can embed it and use it in the best way so it's accessible. A big part of this is making sure that the information that we give, of course, it is thoroughly researched, and it is the right information, because this could be used for how we fund moving forward. It will help us pick up those hidden cohorts. It will help us address health inequalities, and it will help us to inform back to our colleagues in NHS England actually where we need some extra support and how we're going to develop. The other thing that's been quite useful with developing this is being able to share that learning regionally and nationally. So Lincolnshire are quite far ahead with their population health approach, and equally within mental health, we're quite far ahead. So we are seen as one of the exemplar sites for being able to draw this information together. We've also developed some training within the programme, and training in the widest sense. So one of the asks very early on was, how can I best get involved to support people who might be experiencing mental health difficulties? What does that mean to me? And very often we talk about people who experience serious mental illness, but we also have people that become very anxious and depressed, and we have multiple services to do that. But what do you do as an individual if you need to support that? And we have colleagues working in A&E, for example. We have a new mental health urgent and assessment centre that will support that, but everybody needs a little bit of understanding so that we can really walk alongside individuals and help each other actually find the best way to move forward. So we did develop a training offer. We continue to develop that. It's been designed collaboratively with our experts by experience. So there's some brilliant YouTube clips. I would encourage you to go and have a look at them. They're all hosted on It's All About People at the moment, but we'll be moving across to our Hey website as we move forward. We want to make sure that people understand the language that we use, and that we understand the language that we need to use, I think it's fair to say, so that it's accessible and we're supporting people at the very best place that we can. I mentioned earlier psychological interventions. These have got to be the backbone of what we deliver. So we're moving to that holistic framework. Psychological interventions makes it sound quite scary, but really it's about making sure that we're working in a person-centered way, that we're using formulation. So we talk about formulation in secondary care services, and that means a person's journey, a map of how they're going to move from A to B, really, and what we need to put in place. What are the tools that that person needs in place to help them move from A to B? So we want to make sure that that also supports people to reduce social isolation. It means that we can manage any risk that might be presented, because we need to be honest about that. We've talked about dealing with suicide and how we might prevent suicide, most importantly, but we need to manage risk together safely and proactively. And that means pulling everything around that individual so that the person's in the middle and everything's working around them. And there's no cliff edges, and there's seamless transitions. And that's all very jargony, but that's genuinely what we're trying to achieve here. Everything's got to move beautifully together. As I said, the co-production network that we host here within the mental health sphere is co-facilitated between LPFT and Shine Lincolnshire. It's a huge part of what we do. We are very, very proud to have experts by experience sat making decisions with us at the most senior level, all the way through to leading projects of work at that locality level, or even just coming along to share their experiences, because there's value in that. And for me, the network has to provide a space where people can make those relationships, and that will grow other ideas and initiatives. So Our experts by experience are involved in making decisions around funding. They're involved in volunteering in some of the wellbeing hubs that Sarah's alluded to. They make up a part of our workforce, which we're incredibly proud of, with our peer support workers within the Recovery College, across Shine Lincolnshire. We want to make sure that we're growing and developing those roles, and we're going to move forward into this place now, I think, where we're going to see that progression and that work grow. We are referenced again as leading the way with co-production, and we're making more and more connections regionally. I was just on a call earlier with some colleagues from Birmingham about how we're going to take this forward and what that means really for really setting that out whilst protecting people who might be experiencing mental health needs within the co-production network, because we are, as we know, we do have vulnerable people in that arena. So it's really important that we develop that understanding, and that also gives us opportunity to bring together physical and mental health. So this has become fondly known as the onion. It just sets out really how we are embedding our experts by experience. What I will say is everything that we do in the co-production network is co-produced. This isn't something that we've done in isolation. It's been worked through gradually and agreed so that we all feel that we have ownership across this. You can see that right from the heart of the onion right out to the partnership groups that happen at a locality level, and embedded within that is our trauma-informed care community of practice. So I am just going to briefly talk about the trauma-informed approach. It's something that as a trust within LPFT we have signed up to, and it underpins our strategy moving forward, but it also underpins the way that we need to walk alongside individuals. There are 6 principles of the trauma-informed approach, and Sarah mentioned earlier the Together We Will statements. They were co-produced around these 6 principles, and they are a philosophy, a way of working, so that we're ensuring that people are kept safe, that we trust each other, that people are empowered to have choice, that when we do anything, we collaborate together, and that we're always considerate of different cultures. And so we're inclusive in the way that we work. Following the Together We Will statements, they've now been utilised within a piece of work for the Lincolnshire system called Our Shared Agreement, that's really setting out what the standards are going to be moving forward for Lincolnshire, and how important it is that we embed it in everything that we do. So here are the Together We Will statements. We're absolutely committed to these. They are embedded in the work that we've done with the No Wrong Door documentation. We genuinely believe that we need to value each other, that we need to offer a safe, non-judgmental environment. So we're open and honest to ourselves. When we talk about continuous improvement and learning all the time, that has to be done safely, and we need that open and honesty and that trust together. We want to make sure that we choose together, so we've got active listening and we're taking the time to make these changes. This is a big piece of work which will have huge impact moving forward long after I've retired, I hope. We want to make sure that we walk alongside people, and that includes our carers and everybody that's involved in the care, that we respect each other, we put the person in the middle, and that we empower each other. So together we will make no decisions about you without you is absolutely the mantra that we need to embed. I'm going to hand to Sarah now, who's going to finish us off with this so that we've got some time for questions.
So I think you're all going to know, so what's happening next then, really? Obviously, one of the things we want to do is make sure that the Lincolnshire Citizen offer is in place. So there's lots of things that are involved in that, but making sure that, for example, hoarding, which is one of our core elements that we're looking at the moment, we're starting to look at what the support might look like for people in that particular situation. Homelessness is still something we still need to make sure is a little bit wider across the county. We're hoping that we can have some, for example, paid people with lived experience. And we want to just basically make sure that we're turning that triangle continually as we move forward. The locality mental health teams, they need to be fully operational across Lincolnshire. We're there with it in many places, but we want to make sure that we've got that level of consistency and that everybody feels truly integrated in part of one team. And as we said earlier, the lanyard doesn't matter. It's about making sure you work in those teams. We've got other programmes that sort of are part of this, really. SMI health checks are really important. So those with serious mental illness, making sure that not only have you got access to it, but then there's some meaningful interventions afterwards that can support people who require that. We've got increased access to psychological interventions as well, with some pharmacy resource and provision that we need to make sure is in place. And of course, our digital offer, we're aware that we still need to do more around that. We've got some digital kiosks. We need to make sure that they're even more meaningful and that they have some information that people can access, because not everybody is able to necessarily use a laptop or a smartphone, for example. There are some more apps that we want to put in place, and AI. Use of that, I think, is becoming the bigger thing. I'm not quite so familiar with how that would work, but I'm sure we'll all work that out as time goes on. And the keeping well guidance is something that we're really keen to make sure that we support people if you are either waiting for treatment, for example, or to make sure that people are supported if perhaps they are not able to receive support immediately in the way that they might otherwise want to. So we need to make sure that we've got some additional support in place for people like in that situation. Transitional pathways, we've alluded to those earlier, but obviously we're well aware that we need to make sure that this part of the programme links up really closely with children and young people, but also older adults. It's really key that we do that and that we link into the new frailty strategy that's been released for Lincolnshire. We're also keen to make sure that we always talk about a population health management approach. A part of that is data, but we know that the far more meaningful part is about that working relationship and getting people to understand what they think that they can support in the local area. It's making sure that we can address the health and social inequalities that are identified across the patch, and we can use that PHM approach to address that. And then system interoperability, that's obviously key for Lincolnshire, making sure that we can all work together closely from a digital perspective across the piece. And obviously also supporting the suicide prevention strategy that is also been recently released from the public health team. This is about the coming soon keeping well guidance, so hopefully we will be able to share that with you a bit more. I think it's out for elements of consultation, but we'll certainly be able to share that with you as and when that's available. And then how will we measure success? Because it's really important, isn't it, that not only once we've done this, that we know whether or not we've achieved it. So achieving the Together We Will statements is obviously part of that, and probably the more meaningful part of it. Service user feedback is also really key, because people will be able to tell us whether or not we think we've got where we were intending to, and also where we still need to go now. There was a vision from the MHD-LDA Alliance, for example, that we needed to make sure that we actually achieve that. I think we've got a slide that will probably show you what that vision is, but that's been co-produced by all the partners together. We've got some outcome measures that are being embedded into evidence-based practice that will also become key parts of it. Performance data and outcomes are obviously also part of that. We have targets that we have to achieve, as you would expect within health and care, and of course the long-term plan deliverables themselves were also part of that, which was what guided this programme originally. Public health, you'll be able to see on the observatory, set out lots of the JSNA, so the Joint Strategic Needs Assessment challenges, so things that Lincolnshire had particular issues that they needed to address, and some of those things we want to be able to see a change, so we want to be able to turn the triangle of some of those to make sure that we actually start to address some of those challenges. And then there were some priority objectives that the Alliance had identified. So we need to be able to see a change in those things to make sure that we've actually helped towards that. This was the vision that we were referring to. So the Alliance has pulled together across all the partners. Together we will promote wellbeing for all and enable people with a mental illness, dementia, learning disability or autism to live independent, safe and fulfilled lives in their community. There we go. So that's where we would go for questions. And I think now is probably the time if anybody does have any questions, so that we don't completely run out of time.
Thank you, Sarah. So if I can just invite our panel members to flick their cameras on if they can now. I think you should have access. I think we might have had a little technical hitch earlier. And we're very happy to take any questions moving forward. So if you just want to raise your hand, introduce yourself, please, and ask some questions, and then we'll invite the panel to answer them. or we could have stunned you all. Teresa, can I invite you?
Thank you. So everyone calls me T. I work for Lincolnshire Domestic Abuse Specialist Service, and I'm just wondering, I was looking at your map of, can't remember what you called it. Let me just go back and look. Your Wellbeing Matters, your local guide to support your well-being. I'm just wondering if there's not a, so I suppose that's about support, but I kind of feel that domestic abuse is kind of left out. And I know it's more like it's sort of it's a bit of a tangent. It's not a directly related only to mental health, but that's one of the most common problems when someone's experiencing DA. And I was wondering if there's an opportunity for us at LDAS to add our QR code and our details as part of that sort of map of support.
Thanks, T. And I think that's a really good observation, isn't it? I think we're always looking, as I've said, to iterate the pieces of work that we're producing. And what I will do following this is I'll put you in touch with our comms and engagement arm of the team, if you like, so that we can have a think about how we include LDAS on that moving forward. I think, as Sarah says, and I might invite Cavill in, actually, if that's okay, Cavill, to talk about how you've developed this, because this has been developed in one of our particular primary care network areas, LHP. So it won't look exactly the same for every PCN area. But Cavill, can I ask you to just talk to T about how you decided what was on that map and how that was developed, please?
Yeah, hi everyone. So just introduce myself. I'm sorry I was a bit late earlier on. So I'm Dr. Patel. Cavill's my first name. I'm the clinical director for Lincoln Healthcare Partnership, PCN. I work closely with Sarah and Victoria in the CMHD program as well. And so essentially, we have locality meetings where we have lots of input from LPFT. Rachel Constable, I think she's on this call as well. She sort of represents IPBT. We as GPs go to that meeting as well as the mental health champion for the PCN. So what I'm trying to say is there's lots of people involved in that locality who have developed this. And T, you're absolutely right. I think DA should certainly be on that because it transcends, across all borders and all cultures as well. And perhaps we need to sort of consider adding that in. So totally agree with your point about that. But essentially, that's how we sort of came to it. But as Victoria said, the more people that put input into it, the more clearer and more accurate the support mechanism becomes.
Thanks, Cavill. I hope that's helpful, T, and I'll make sure that you're linked in where you need to be moving forward.
Yeah, that is helpful, and thank you. And it wasn't, please don't misunderstand me, it wasn't a criticism. It was just, I just feel like there's a gap, and I feel like I think it would be great if we could be included, because really a lot of the deaths through domestic abuse are not only homicide, but they're also suicide. So the mental health overlap is massive.
Yeah. Brilliant, thank you. And it's always great to hear observations. That's what we're here to do, is to iterate and include people where we perhaps have missed them out. Yvette, can I invite you next, please?
Hi, I'm Yvette Foster and I'm the Acting Strategic Lead for Social Prescribing for VCS. Really, it's not a question, it's just thank you very much for identifying hoarding as one of the gaps that we've got at the moment. That was something that was identified at our Strategic Lead meeting yesterday. So it'd be nice to feed back to them that that's already in hand. Thank you very much.
Brilliant, thanks Yvette, really appreciate that feedback and nice to see you on the call. Jason, I can see you've got your hand up. Would you like to come in next?
Thank you. Yeah, I'm Jason Oxby. I'm Service Manager for Housing and Support Solutions for Boston Borough Council and East Lindsey Council. Got a couple of questions, please. Probably about 10 years ago, you used to have an assertive outreach team. So you had someone who, say, displayed bizarre behaviour out in the community who isn't likely to come to yourselves. Do you now have a service to go out and actually see people rather than expecting them to come to you all the time? That's my first one. Thank you.
Thank you, Jason. I'm going to ask Nick who is our SRO for the programme and works in LPFT. Nick, would you like to come in and answer Jason's question?
Yes, of course. Hi, everyone, and hi, Jason. Yeah, assertive outreach teams were something that we had a number of years ago. I guess specialist services developed favour and then sometimes drop out of favour, but a service that was really important in terms of, as it says on the tin, really engaging assertively with people that were more difficult to engage with, kind of maybe avoided appointments. But the function of assertive outreach continues to exist within our community mental health teams, and the majority of the appointments that we do are in people's homes and out in the community. So yeah, it's definitely not about just inviting people in to see us, but yeah, it's definitely an area we need to give some more thought to as a discrete function. We had that real clear model, I guess, of how we engaged people who were more difficult to engage or avoided services for whatever reason, and the kind of some of the challenges that were happening in their life. So certainly something we've talked about, Jason. How do we make sure that remains really focal to some of the work? But yeah, probably a little bit more to do to replicate what was there in the past. But yeah, really good point. Thank you.
Thanks, Nick. Jason, would you like to come in with your next question?
Yeah, thank you for that. It's useful to hear that, and it's nice to know that you are considering that sort of cohort. It's who we deal with on a day-to-day basis, who we really struggle to get into services. The next one was around dual diagnosis, because I understand there isn't a service in Lincolnshire. So again, we get lots of homeless people who have a mental health issue and an addiction. We often find that the addiction is blamed and then they don't get any help from mental health services. So I just wondered what's happening about that, please.
Thanks, Jason. That is a question that comes up for us, and we do have a dual diagnosis work stream that we do work closely with. It does sit outside of the scope of this programme, but we are starting to bring those things together. Sarah, Jade, would you like to comment on Jason's question at all, please?
I'm not sure if Lisa is on here or anybody from Public Health either, but certainly I know we do have, as you've said, we have got a dual diagnosis work stream. There is a strategy in place, and I know that they're currently looking to increase the impact of that. I'm not sure that I have the full level of detail of what that currently looks like, but certainly, Jason, we can get that to you, and I'll make sure that we address what that current model looks like. I believe they've been doing a lot of work around that, or Nick might be coming in to say that.
No, I was going to say that again, a really good point. We don't have a specific service because the issue of dual diagnosis sits across every single service that we have, and all sectors and primary care and into the communities. So yeah, there is a strategic group for Lincolnshire ensuring that people's needs are met, and we're looking at that from all angles. But I think you'd be probably quite interested, Jason, in some pretty recent NHS England guidance, because I think we have found ourselves getting into that chicken and egg type discussions. You know, deal with your substance misuse, then we'll treat your mental health. And people go, well, I can't stop using the substances because of my mental health. So, you know, and I guess the way we've not been commissioned in a joined up way has led to some of that. We've got really close relationships as an organisation with We Are With You and strengthening those all the time. But there's still them challenges when you commission slightly differently. But the new NHS England guidelines, in summary, says get your act together, speak to each other, work in the best interests of the people, and stop being precious about who should treat them. So that's something we need to make sure we embed going forward, that we're here for people, we're not here for diagnosis, labels, etc. So fingers crossed we can get that embedded and work through that guidance and make some more sense for people.
Thank you.
Thanks, Nick. That's really helpful. And I think, you know, you've said it in a nutshell. We're here for people, aren't we? And that underpins everything that we do in this programme. So we absolutely do need to get our act together where we haven't got it together. But like I said earlier, this is a massive piece of work, isn't it? So it's about us all moving together and being respectful and understanding how best to do that. Jade, can I take the last question from you, please? Or
it was just really, I mean, I don't know how I follow on from Nick there, because that was just brilliantly put. But I suppose just from my point of view, I suppose that a lot of work is going into the team around the adult system that we've got in place currently, which works a lot with dual diagnosis individuals. And I think Nick's point about it's very much, the process needs to be person-centered, with everybody around the table just being very honest about the challenges they're facing for these individuals who are incredibly complex, but working collaboratively and stripping down all those professional barriers that sometimes can present event when we're all faced with, well, we do this and we do this. And I think Team Around the Adult is very much working towards that, really stripping back and looking at this individual and who can do what, when and where in the best interests of that individual. So I think the systems are starting to be put into place, but Nick's absolutely right. I think at some point it's just getting everybody around the table and saying, right, stop mucking about here. We just need to get this person where they need to be.
Brilliant. Thank you so much, Jade. And of course, that underpins the trauma-informed approach, doesn't it? And everything that we talk about within that. So that's wonderful to hear. I can see that there is a question in the chat, or the Q&A as it's termed on here, about how will you be upskilling current staff members in LPFT so that they are able to offer evidence-based psychological interventions with confidence? That's a huge question, isn't it? There's much work going on around that at the moment. We are accessing various placements where we're also working with our universities to support that flow through. It's going to take a long time, is the honest answer, I think. We're always encouraging people to look at what's appropriate within that remit to be able to do that, and we will always work to support you to access the skill sets that you require so that we can upskill people. Some of it is also about iterative learning, I would suggest, and so a lot of the work that we're doing within the trauma-informed community of practices, the work that we do in reflective practice, the work that we do across that psychological intervention strategy is all being part and formed as we speak. So it's an ongoing process. It's absolutely a gap, and we recognise that, and we'll seek to continue to upskill people as much as we can, and that will gradually move through the system then. Is there anything you want to add to that, Nick?
No, I think that covers it. I think the NHS England offer around training was quite difficult to manage because it was lots of 2-year training courses and kind of relieving teams of capacity to get people off and do that training. It was quite a reach, really, but we've had some people do that training. We've brought in new roles around mental health wellbeing practitioner, which is very much psychologically kind of informed new post. But the next bit and the challenge for us is ensuring all of our staff have access to that psychologically informed practice and training. So it's all coming, it's all kind of in training, in practice, and lots of CPD packages available. But yeah, we just got to make that land now. And key to it all is really good quality clinical supervision to develop your skills, which is the other bit of it. Training by itself's fine, but we often find if you don't then continue to develop, it's not all that effective. So, but yeah,
Absolutely.
Work in progress.
Lovely, thank you. T, I will take the last question and then we will finish if that's okay.
So my question is there anything around that's not just talking, that's actually about dealing with stress in people's bodies, like more somatic type therapies?
So I suppose my response to that is there is a lot of stuff around about that, and there is a lot of stuff happening in the VCFSE sector that we are starting to fund through that. I think it's a really good question. My background actually is not just as a cognitive analytic therapist, but also as a music therapist. So I'm very passionate about us looking at other ways to do this. We do have some alternative practices, and they are evidence-based and they do sit within the NICE guidance. So I think we need to grow some of that in Lincolnshire, but we need to recognise a huge amount of skill sets there are in the voluntary and community sector, and that's some of the funding that we're putting in so that we can help that. Because what we want to make sure that we do is that we don't create a dependency on the NHS. This is not just about the NHS delivering everything. This is about the whole system doing that, and also about people taking responsibility to manage their own care and their own mental health and well-being. So there's a very fine balance there, isn't there, between what we can manage ourselves and what we provide. And I think this will all grow over time as we take our next steps on this journey together.
Yeah, 100% agree with everything you just said.
Thanks, T. So on that note, I think we'll leave it there. Thank you very much to all the people that have joined. It's been an absolute delight to share with you the work that we've been doing, and thank you to our panel members for stepping in and answering some of those questions. We will look forward to seeing people on the next webinar, which is coming up in November, and we'll close it for today. If there are anybody that you're aware of that's missed it, then please invite them to have a look, and we will get the slides sent out to you forthwith. Take care, everybody. Have a good day.
Thank you.